also wanted to start really with a self-evident fact which Andy referred to on his second slide, which is that compensation, and even more so money spent on legal costs, is money which is needlessly diverted from patient care. Every case that we see is traumatic for the patient, it's traumatic for the staff involved and also for the organisation. And the cost attached to claims can be very, very large indeed. We recently had a judgment on a cerebral palsy claim, cerebral palsy at birth, which received an award equating to just under £14.5 million. So that's for one individual. And that's an avoidable cost. It's also a tragedy for the family, and it's a tragedy for everyone who was involved in that event. So claims and litigation are never a positive thing. What they can be, though, is a hard financial incentive for the reduction of harm. And they can provide an opportunity for a very real impact on the balance sheet when measures to reduce harm succeed. So at the NHSLA, we've got quite a unique and you might say pretty skewed perspective on when things go wrong in healthcare. We get about 12,000 new clinical negligence claims annually from the NHS in England, and last year we spent just over £1.1 billion in resolving claims. That £1.1 billion is still only part of the picture in terms of the financial impact of negligence. And that's because the most expensive claims are resolved generally by way of a lump sum payment up front for things like care and accommodation, followed by annual payments for care costs for life. So typically, a claim settled in year might see a payment of £3 million up front, but then an ongoing income stream, which is not visible in that annual expenditure, of around £150,000 to £200,000 per year, which can stretch on for the next 70 years or so. There's also typically a time lag from when the incident occurs to when a claim is received to when that claim is resolved and it hits the books in financial terms. And it's not unusual for us to receive new claims which date back to the 1950s and 1960s. I had a quick look at our database just before the conference, and we're currently managing a claim from the dating back to 1969, which relates to a retained swab. We're also dealing with some really expensive claims from the 1960s and 70s relating to birth injuries. So these claims take a long time to come through the system. There's also ongoing payments and incidents which may yet become claims, whether we know about them or not, and they also have to be provided for financially. And currently, this is a provisions figure, it's a financial accounting figure which sits in the government accounts, and that stands at just over £26 billion. So we've changed our pricing to ensure a closer correlation between claims experience and price, so that organisations who have fewer, less costly claims pay less for their indemnity cover. So put simply, avoidable harm comes at a high financial cost, and where that harm increases, so will the cost of obtaining indemnity cover. Those who take steps to reduce harm will see their claims reduce with a long-term financial benefit and reduction on their contribution to CNST over time. So the financial costs of harm can't be seen in isolation, and they can't be ignored if we're to avoid funds being needlessly diverted away from patient care. So coming on to the way Andy structured it, looking at data and culture, and what we can do to help. What we can do is, in relation to data, looking at it back to front, we can support analysis and learning from claims and sharing that learning across the service. So organisations which pay attention at board level to their incidents, complaints and claims and how they fit together and how they interact with the price of their indemnity cover are those best placed to address the causes of that harm and so reduce their costs over time. And we can help with that with detailed analysis and information. We've distributed scorecards on claims experience to the NHS, to all of our members, and information is available on a live extranet which we have, which drills down into the details of the claims which are logged on our system, and provides benchmarking in real time on a regional, national and specialty basis. And we can also provide you with direct support from our safety and learning team, who also operate on a regional basis. Looking at a culture, handling of incidents is critical, and incidents can become complaints, can become claims, because somewhere along the line an opportunity has been lost to provide an honest explanation to the patient when something's gone wrong. A while ago, we issued a leaflet which I referred to in the Duty of Candour session yesterday. It's a short summary called Saying Sorry. There's copies available on our stand in the main hall if you want to take one away with you. But the message from our perspective is that because we're not an insurer, we never have and never will say that we won't cover a claim because an organisation has said sorry, offered an apology or offered an explanation. It's quite the reverse, in that a sincere and meaningful apology is more likely to prevent a claim than start one off. In terms of culture, we're also strong supporters of mediation as a way of resolving disputes, and it's our experience that bringing patients and families and the healthcare team together can be key to finding small lessons which can make big improvements and lead to better outcomes, both financially and for the patient and the staff involved. In terms of design, we've stopped assessing trusts against risk management standards. We felt it was burdensome, we felt it was expensive for the NHS, and there was no evidence that that was linked to reduction in claims. This year, we provided support to the Sign Up to Safety campaign, where we offered financial incentives to those organisations that evidenced through their safety improvement plans that they could reduce the harm that leads to claims. So trusts were able to bid for a one-off payment of up to 10% of their CNST contribution, and we provided the clinical claims scorecards, which is an interactive analysis tool so that organisations could analyse their claims profile and really focus in on those areas which would make a difference to their ongoing financial costs. And just a few facts and figures on the Sign Up to Safety incentive scheme. We received 249 bids from 114 member trusts, and we approved 67 of those. Those are plans from a wide range of safety improvement areas. Just over £18 million was allocated to successful bidders. 10 trusts successfully submitted plans relating to whole safety culture improvements, which included technology, training safety leaders, communication, and that allocation amounted to £5.2 million. 4 trusts received funding for bids related to human factors, so education and related human factors initiatives. And that funding amounted to £1.4 million. So that money's been centrally allocated. That's been allocated by Department of Health. That doesn't come from the CNST funding. And plans are already in train. And we'll be undertaking a comprehensive impact analysis of how they progress over the course of this year. We're really looking forward to sharing the outcome of those plans with our members. And we've got 2 maternity events coming up in the next month, and then potential for 2 further events in the spring, specifically focused on the human factors plans and some of the things that will be coming out of those. So just to wrap it up, if there's one thing that I really wanted to highlight from the paper, it's that need to engage with the link between the causes and the financial consequences of harm. And we can help with that, and we can help with providing the financial backdrop and the analysis to demonstrate how improvements in safety can drive unnecessary costs out of the system and put money back into patient care where it belongs.
Thank you very much, Helen.